Want a website with unmatched power, speed, and control? Try Bluehost Cloud, the new web hosting plan from Bluehost, built for WordPress creators by WordPress experts. With 100% uptime, incredible load times, and 24/7 WordPress priority support, your sites will be lightning fast with global reach. And with Bluehost Cloud, your sites can handle surges in traffic no matter how big. Plus, you automatically get daily backups and world-class security. Get started now at Bluehost.com.
This episode is brought to you by Peacock. The new Peacock original documentary, Matthew Perry, A Hollywood Tragedy, dives deep into the beloved actor's rise to fame and his tragic death. 5 people, including Perry's personal assistant, 2 medical doctors, and an alleged Hollywood drug dealer known as the Ketamine Queen, were charged with conspiracy to illegally provide Perry with the ketamine. Explore the details of the case in this heartbreaking special, streaming now only on Peacock.
This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction practice. This podcast offers Category 1 CME through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we will be discussing 4 articles that changed our practice this past year. Sonya, how are you doing? And you want to give a little background about this episode?
Yeah, I'm doing great. So this is articles that changed our practice, and we pulled the 8 most, we call it impactful articles from the past year. These are articles that we felt were relevant, helpful, and actually changed our practice. And we're going to do 4 in this episode and then 4 in the next episode. So if you like this episode, stay tuned. In 2 weeks, we'll release another one with the second 4. And we presented this at the Pennsylvania Society of Addiction Medicine Annual Addiction Symposium. So if you like what you hear and you want to hear more lectures from addiction docs in Pennsylvania, you can sign up for the Addiction Symposium next year. I did, John, want to share one thing with our audience before we start that's not about articles that changed our practice. I'm sure that our audience has been hearing in the news a lot of changes in the federal government, including threatening Medicaid, and a lot of other changes that might hurt our most vulnerable patients. And if anyone wants to know how they can respond, ASAM has a legislative action center and a political action newsletter that will kind of give you things you can do, what's going on that will affect addiction medicine and our patients. And I will put a link in the show note how to sign up for the newsletter and the website to go to for the ASAM Advocacy and Action program. So I just wanted to let people know I'm going to include that in our show notes. So, John, you ready to talk about some articles?
Yeah, let's get started.
So before we start, I just want to tell everybody that, there's a lot of research to keep up with there. Addiction medicine is constantly evolving. And as clinicians and researchers, we do have a professional obligation to keep our medical knowledge current. The American Medical Association Code of Ethics, which has been adopted by ASAM as well, says that the physician must engage in continuous learning throughout professional life in order to maintain and develop professional knowledge and skills. Like, you have to do this. But there is so much knowledge out there, so much medical publishing. In 2022, which is the last year I could get data for, there were about 1 million articles published and indexed in Medline. And there was a bunch of others published, of course, not Medline indexed. And it's this ever ballooning collection of articles. It's a little bit overwhelming. There's no way for any single doctor to read all those articles. And then the other problem with the addiction medicine literature is that a lot of the research is not really actionable. So you might see research about a medicine that's not readily available, like the the GLP-1 agonists like semaglutide. It's not affordable for most people, or, the patients might be different than yours. So the people in the study might not be the same as your patients. Or it's interesting, but you can't really act on it. I'm going to give an example. Our St. Max's director of experimental psychology, Dr. Michael Treadway. If you're listening, Dr. Treadway, we love your paper. But he wrote a paper about how the anti-inflammatory TNF alpha antagonist, something called infliximab, it improves deficits in motivation and reward seeking in depression. So this is like treating depression behavior with anti-inflammatories. That's amazing, but I totally am not going to be giving infliximab infusions. for my depressed patients yet. It's just not really available. Um, and so our service to you, and this is why we like to do the podcast, is to pick out articles that you can actually use that are relevant to your practice, that are medications that are available to you. And in this episode and in the next one, we're going to cover the 4 that we thought were the absolute most relevant. So you ready to get started, John?
Let's roll into case 1.
All right. And just to note, these are real cases. These are not prettied up teaching cases. These are our actual patients. So the first is a 31-year-old man. He's seeking a benzodiazepine taper as well as injectable buprenorphine to treat both benzodiazepine and opioid use disorder. He's currently taking prescribed long-acting buprenorphine, 300 milligram injection every month, diazepam, 60 milligrams. He's been prescribed that daily. He's taking illicit fentanyl combined with xylazine and whatever, who knows, about 50 grams daily, and also illicit alprazolam, about 10 milligrams every night. So this is a major kind of cocktail. And he's found himself unable to stop the fentanyl or the alprazolam, even though he's on the highest dose of injectable buprenorphine plus prescribed diazepam. He declines methadone, he declines inpatient treatment. So what I used to think before I read this article was that I would tell the patient the buprenorphine is not working. What's the point of taking it if he continues to use so much fentanyl? Maybe I'm just adding fuel to the fire, potentially contributing to a future overdose from polypharmacy. I should probably decline to continue the buprenorphine. It's not working. Like, why would I continue it? So, John, if you had a patient like this, or let's say before we read this article, would you have said, yes, let's continue the buprenorphine, or no, let's stop it because it's not working?
I certainly would have contemplated another strategy. I don't know if I would have stopped it, but I would have had the same questions. Is this an effective treatment for this patient?
Right. And is it maybe making him worse? Is it another opioid we're adding to his mix? But then I read this paper called The Protective Effect of Buprenorphine, quantifying a potential protective effect of buprenorphine on fatality risk during acute fentanyl exposure. So the clinical question in this paper was, in patients who died of fentanyl overdose, is there a difference in the fentanyl blood concentration between those who also had buprenorphine in their system and those who did not? It was a study of people in West Virginia who died of fentanyl overdose in the 2010s from 2011 to 2020. All of them got post-mortem toxicology, and the researchers looked at the fentanyl, buprenorphine, and norbuprenorphine levels. And for those of you who don't remember pharmacology, norbuprenorphine is a buprenorphine metabolite, and its presence indicates that a patient has been on the bupe long term. And by long term, I mean just more than a few days, rather than, say, just taking it once or just taking it the day of overdose. The main outcome was the association between the fentanyl, the buprenorphine, and the norbuprenorphine levels at the patient's time of death. So the primary outcome is, what is your fentanyl level when you died, if you had buprenorphine in your system, and if you did not. And so people who had buprenorphine in their system, their fentanyl level was 0.37 micrograms per milliliter. People who did not, their fentanyl level was 0.27 micrograms per milliliter, so much lower. And basically what this means is that you had to have more fentanyl in your system to die if buprenorphine was present. You can also see that the bupe-nor-bupe ratio less than 1, that means they've been on buprenorphine for a few days at least, had much higher lethal fentanyl concentrations than those who did not. Their fentanyl concentration was 0.38 micrograms per milliliter. So those who have been on buprenorphine a few days had even more protection. And there's a nice graph, and it shows how the lethality curve of fentanyl kind of shifts to the right in the presence of buprenorphine, and even more in the presence of um, long-term buprenorphine with that bupe-nor-bupe ratio less than 1. So what I would do now with this gentleman who's struggling with illicit fentanyl, even though he's taking a full high-dose buprenorphine, I would say, we need to keep you on the injectable buprenorphine no matter what. It's the reason you likely haven't overdosed, and we'll work hard to get you off the illicit fentanyl. Whatever you do, do not stop those buprenorphine injections. And then as an aside, I can work with you on a benzodiazepine taper if we can get you off the illicit alprazolam. And so, the clinical bottom line from this paper is that the buprenorphine is protective not just because it makes you take less fentanyl, it's protective because it actually blocks the fentanyl and protects you from overdose even if you continue to use. And I kind of knew that if I thought about the pharmacology logically, but it hadn't sort of this paper really brought that home to me clinically. So what do you think, John? Did this paper change your practice?
Um, I think from a pharmacology standpoint, it kind of makes a lot of sense and reinforces that. I think I kind of almost view this as like a naloxone type life-saving medication, right? It's kind of has that kind of receptor partial agonist activity. I think if you have the medication on board, I feel much safer with that patient, the community for their health, right?
Yeah. Yeah, me too. All right, ready for our next article?
Yeah, case number two. This is a 54-year-old female with a history of diabetes, hypertension, anxiety, and alcohol use disorder who presents to the hospital for the 58th time in the past 12 months with alcohol-induced acute on chronic pancreatitis. She's admitted for pain management, electrolyte replacement, and alcohol withdrawal management. The patient states that she plans to never drink again and is discharged home against medical advice on hospital day 4. She expresses no interest in going to rehab, stating that, quote, it doesn't work for her. Her hospital course follows a predictable pattern identical to the 20 plus encounters that she last had in the hospital, including the one from the previous week. What I used to ask myself for these evaluations was, in addition to managing the patient's alcohol withdrawal and offering rehab, what else can I do to kind of break this cycle? And I think I'm a teacher. I know you are too, Sonya. I feel like oftentimes it's gotten better with time, but for many years, if I asked one of my residents like what the management of alcohol use disorder was, the answer was always like an alcohol withdrawal protocol kind of regurgitation. That was kind of the extent of the knowledge. So um, I read this article called Outcomes After Initiation of Medications for Alcohol Use Disorder at Hospital Discharge. And it's from JAMA Network Open in March 2024. And it kind of changed my perspective a bit.
So wait, a quick question. I know these are supposed to be real teaching cases. So did this person really end up in the hospital 58 times?
Correct.
Oh my gosh, poor person.
Yeah. Actually, yeah, it's kind of a bummer. This person just died last week, I found out. But yes, they've been in the
Aw.
hospital many times. It was like 2 to 3 times per week at some weeks. So the clinical question, does initiating medications for alcohol use disorder at hospital discharge improve 30-day outcomes? And that includes mortality, hospital return in Medicare beneficiaries. So to give you a little bit about this study, it was a retrospective cohort study using 2015 to 2017 CMS data. It was a population of 6,794 unique Medicare patients admitted with alcohol-related hospitalizations, predominantly in 2016. The exposure was a medication for alcohol use disorder um, within 2 days of discharge, and so that included naltrexone, acamprosate, and disulfiram. Outcomes were there was a primary outcome, which was like a composite of mortality or return to the hospital within 30 days. Secondary outcome was related specifically to ED visits, readmissions, and follow up care. A little bit about the results. This is an overwhelmingly male population, 67.4%, a median age of 54. They had high rates of dual diagnosis with anxiety and depression. Not surprisingly, in terms of medication initiation during that 48 hours within hospitalization, it was very few patients. So these are captive patients. They're not captive, but it's a captive audience. You have an opportunity for intervention, and in only 2% of hospitalizations was one of these medications initiated. So a lot of missed opportunity. In terms of the primary outcome, which was medication for alcohol use disorder initiation, reduce the risk of hospital return or death by 42%. And when you kind of subdivide that, it really is the driver of that was return to the hospital, not death. So mortality, even though that was part of the composite outcome, had really very limited data that made any statistically significant difference. In terms of secondary outcomes, it reduced all-cause ED visit by 0.57, and that's an incident rate ratio. All-cause hospital returns was decreased 0.56 IRR, and all-cause readmissions was reduced with a 0.42 IRR, and it had no effect on mortality whatsoever. There's a really good graph from this article kind of showing these branch points and kind of the vastly different outcomes between the two groups, even though it was a small subpopulation. Kind of revisiting this exact same case, kind of what I do now, I think that as the patient's alcohol withdrawal subsides, in addition to, the standard old recommendations about inpatient rehab, I do discuss initiating medications for alcohol use disorder while the patient's in-house, as long as they're clear enough to give consent and understand the medication that they're receiving. And if the patient is agreeable to this, I would start this at that hospitalization with plans for discharge and outpatient follow-up. And even one step further, I think that there's a big emphasis on hospital discharge follow-up and continuation of medication, especially some of these like a depot formulation. I think that even without follow-up, this could have a marked impact on risk reduction for these patients.
Well, right, and you've been tireless in advocating for long-acting injectables in the hospital, for alcohol use disorder, and so that would be amazing if the person, when they're feeling like they wanna make a change, they can get their long-acting injection on their way out the door and then have some protection when they're out in the community again.
Yeah, we started a little bit of this, and it was actually interesting. We have our resident discovery day coming up, and one of the residents did a paper on this already from on just our small inpatient service for family medicine, and it was again a lot of missed opportunity, but a very effective in the receiving participants.
Yeah, I was talking to one of our residents too. They gave the patient a, naltrexone injection at discharge. It was great. I'm really happy that they're doing that.
Let's ramp it up.
It's ramping up. Ready for case number 3?
Yep.
So this case, this is a 66-year-old man. He has a history of hypertension, diabetes, high cholesterol, tobacco use, obesity, daily cannabis use. And this is not one of my addiction patients. This is one of my regular medical patients. But during his Medicare annual wellness visit, he shares that he now has custody of his grandchildren and because of his daughter's substance use disorder. And he wants to reduce his health risks. He wants to be as healthy as possible so he can care for these grandchildren as long as necessary. So, what I used to say is the most important thing I can help you with is quitting smoking. Then we'll make sure to get control of your blood pressure, blood sugar, and cholesterol. And I would kind of pretend that the cannabis use just didn't really exist. Um, but then I read this article. Well, like you can't take away people's like medical marijuana. It's like then you're just a big meanie. But I read this paper, The Association of Cannabis Use with Cardiovascular Outcomes Among U.S. Adults. And I think this was the first paper we've ever presented that was published in the Journal of the American Heart Association. It's also super popular. It got cited 44 times in its first year after publication. It's been profiled in over 200 news outlets so far. So this paper really generated a lot of interest. It's also very timely because in 2022, for the first time ever in the United States, daily or near daily cannabis use became more common than daily or near daily alcohol use. So I'm just going to say that again. More people use cannabis daily or almost daily than alcohol daily or almost daily in the US. So cannabis use has just exploded. And I think we do need to know, as well as the benefits of medical marijuana, we have to know about the risks. Well, and I'll stop you here. John, before we did this, did you ever talk to people about negative health effects of cannabis if they
Uh,
asked?
I think it came up a lot, especially like my people with like chronic respiratory issues. They were still smoking marijuana. Um, and I think a lot of it was like harm reduction, switching to alternative forms to mitigate the risk of the combustion inhalation. But I think otherwise, you're right. It's just such a hot topic, and people do not like it when you tell them it's not a healthy habit.
Well, it's so funny. I was speaking to a patient recently who's a daily cannabis smoker with significant lung disease. And I told him that it's not good for his lungs. He said, "But why do they say that marijuana is good for your lungs?" And I kind of wanted to be like, they don't say that. I don't know who says it's good for your lungs,
Why would Tim down at the gas station tell me wrong?
right? And I wanna be nice. I never wanna, like, be mean to someone, especially if someone's been feeding them misinformation. That's not their fault. But I just I when he was so sad, he said, "How come they tell me it's so good for my lungs?" I was like, "Oh my gosh, we've got a long road ahead of us, everybody." But anyway, so the clinical question was, what's the association between cannabis use and cardiovascular outcomes? So this was a population-based cross-sectional study done at a single point in time. It was really big. It had 434,104 adult respondents in this study. It was a survey called the Behavioral Risk Factor Surveillance Survey. It's done by the federal government every year, and it's meant to represent the US population overall. It takes patients from 27 states and 2 territories, and it's a telephone survey. It's performed by the CDC every year. And when this paper was written, that was the first year they decided to ask about cannabis use. So suddenly they had data about cannabis use as well as alcohol, tobacco, and other things. So it's a pretty simple survey. It's 16 questions. And, for example, one is during the past 30 days, on how many days did you use marijuana or hashish? So pretty simple. Another sample question: has a doctor, nurse, or other health professional ever told you that you had a heart attack? So real basic. The outcomes were self-reported coronary artery disease, MI, stroke, and then a composite outcome of all three together. They looked at a bunch of subgroups, people who smoked and didn't smoke tobacco, men versus women, younger people who had high cardiovascular risk and people who didn't. So a lot of subgroups, and then they really focused hard on trying to model the synergistic risk from tobacco and cannabis together because that's been a kind of a contaminant in a lot of the other studies of cannabis and heart disease is that tobacco is almost always present as well. So it's hard to tease out the effect of the cannabis alone. I just wanted to bring up two significant limitations though before we talk about the results of this study. The first is that people who use cannabis daily were really different at baseline from people who did not, or people who used it but not daily. So there are three groups: daily cannabis users, non-daily cannabis users, and people who didn't use it all. They tried to adjust for the differences in the group, but I'm sure there's a lot of unmeasured confounders, which might lead to differences in all three beyond cannabis use patterns. The other limitation is that this is a point in time study, so it's not able to assess causation, only correlation. In fact, it asked about cannabis use in the past 30 days, but cardiovascular disease at any time in the past. So even reverse, you could even have reverse causality. I mean, it could be that you got cardiovascular disease first and then you started using cannabis afterwards. So it doesn't prove that the cannabis use causes the cardiovascular disease. The other thing is that the effects of cannabis on cardiovascular disease are likely reversible. So just because you use cannabis now or even that you used cannabis in the past and then later you got cardiovascular disease, it still might not be connected. So what you really would need to know is patterns of cannabis use just prior to the cardiovascular event. And we don't have that in this survey. But despite these limitations, it's still the best data set we have on this topic is there an association between cannabis use and cardiovascular disease? So the results show that 30-day past cannabis use is associated with adverse cardiovascular outcomes, with heavier use, meaning more days per month, associated with higher odds of adverse outcomes. Most of the differences in the composite outcome was driven by the higher rates of stroke. Um, Cannabis had a strong association with cardiovascular disease among all the subgroups: general population, people at high risk, people at low risk, younger people, and people who never smoked tobacco or even e-cigarettes. The results are presented in odds ratio, so you can see those who use cannabis had higher odds ratio of coronary heart disease, MI, and stroke. The highest was stroke with an odds ratio of 1.42 compared to non-cannabis users. In people who are current smokers, the odds ratio of a stroke was 2.08, and in people who used cannabis but did not smoke, the odds ratio of stroke was 2.16. So cannabis use appeared to confer an even greater risk than tobacco use in terms of stroke, which was one of the main drivers. In terms of myocardial infarction, tobacco use was the biggest risk factor with an odds ratio of 2.63. So 2.6 times the risk of a myocardial infarction in tobacco smokers. Basically, the highest risk was for current smokers, and people who used cannabis even if they didn't smoke. So, this data does not exist in other forms, and it's sort of stark to see it there, especially the stroke outcome. The other thing I wanna let our audience know is that whenever we're doing a study of risk, it's nice to have a dose response curve showing that the higher dose of the poison, as it were, the worse the outcome. And we do have that in this study as well. The more cannabis you use, the higher your risk. coronary heart disease risk was not statistically significant, but MI, stroke, and the composite index were all statistically significant. So the more cannabis you used, the higher your risk overall. So if we get back to our gentleman who wants to reduce his cardiovascular risk, before I would have told him that we got to quit smoking. And now I would say we gotta quit smoking and cannabis. And I would ask, why do you use the cannabis, and can we find a safer outcome for you that, does not raise your risk of heart attack and stroke? And, after reading this article, I do now ask people explicitly about cannabis use. A lot of people have medical marijuana, and it's on their problem list, and people who have heart disease or high risk of heart disease, I strongly counsel against using cannabis. So, this one has definitely changed my practice.
It's an interesting article. I thought it was a really good point too in like the Live Journal Club that some of our other colleagues brought up the fact that this is not kind of unique to the combustible form of marijuana as well, which I thought was interesting.
Yeah, and if anyone wants to know more, they can listen to our episode where we spent the whole half hour talking about that article, and part of what we talked about was all the ways in which cannabis affects the cardiovascular system, but, we had a guy in the office, I don't know, recently, like, tachycardic, hypertensive, he's already got high blood pressure and heart disease, and he used, a significant amount of cannabis right before walking into the office. And even one of our residents was they weren't aware that the cannabis would have that kind of immediate effect, raising your blood pressure and your heart rate. All right, ready for case 4?
All right. I think this is going to wrap it up for this part, right?
Yep.
Okay. This is a 28-year-old male with a history of opioid use disorder, generalized anxiety disorder, PTSD, and medical marijuana use presenting for routine follow-up. He is currently on buprenorphine and naloxone, 16 milligrams daily for maintenance with 28 months of consistently expected urine drug screen results. The patient has been following up with you monthly in the clinic. He arrived directly from a manufacturing job and is unable to provide a urine sample, as he already went before leaving work. The clinic is overbooked due to a shortage of providers in the community prescribing medications for opioid use disorder, and you are running about 30 minutes behind.
That's not you though, right? That part's not real. You n
Yeah.
never
Yeah.
run behind.
That's the ticket.
Yeah.
So what I used to ask myself when this is I was like frantically pacing which room to go into, I would be like, does requiring a UDS at every one of these visits really increase my likelihood of successfully treating this patient and keeping them in my clinic? And I read this article then called Association of Random Observed Urine Drug Screening with Long-Term Retention in Opioid Treatment Programs for Drug and Alcohol Dependence in February 2024. So the clinical question of this study was, one, what are the characteristics of opioid treatment programs that use high rates of random and or observed urine drug screenings? Number two is, how are UDS practices associated with retention and treatment for at least 1 year? So kind of 1 year plus a follow-up. The methods, this was a cross-sectional analysis of 150 OTPs offering methadones exclusively, so not kind of buprenorphine like the majority of my practice, from 2016 to 2017 on NDA TSS data. So that's like a survey data that's given out, and it's an opt-in survey for these methadone maintenance clinics. Exposure was high UDS utilization. So, it wasn't no UDS utilization. It was high, which they defined as greater than or equal to 90% of clients being tested at their visits. And the outcomes they looked at were primarily retention and treatment for 1 year or more. And secondary was clinic factors affecting UDS practices and retention. So characteristics, 150 different OTPs with a median of 310 clients. High DS utilization was interestingly much more common in the Southeast. In terms of the primary outcome retention, so OTPs with high UDS utilization had lower retention rates compared to those with lower UDS utilization. So like I said, the cutoff was 90% of visits versus less than 90%. So you could still have 88% and be considered a lower utilizer. And the difference at 1 year was 57.2% versus 68.9%. High rates of both random and observed UDS testing were linked to an additional 13% lower treatment retention at 1 year. So if you were doing both kind of high rates and you were actually kind of like making people do them observed, much worse, which I don't know, I'm not aware of anyone actually doing that anymore. Are you, Sonya?
Yeah, I actually do. I do know of programs. I mean, we certainly don't, but still do observed urines. I mean, especially if there's like a, I don't know, punitive element to it, where like you have to stay drug free or some sort of punishment falls down on you. They do observe urine drug screens.
Yeah. I thought that very interesting. A discharge policy was actually really important. So OTPs with a discharge policy for abnormal or unexpected urine drug screen testing results actually showed less impact on retention. So I think this comes back to, like I've said this on many other episodes, for primary care, like managing expectations is really important. So I think that kind of transparency as to like what the policy is at the clinic when you start and as you go through, whether you keep people in treatment or you move them to a higher level of care, however you feel about that. I mean, I know we have our own feelings about that, Sonya. But however you feel, certainly your UDS practices will be less mitigated in terms of treatment retention if you're very transparent with your patients as to what to expect.
Agreed.
So what do I do now? So I feel like this is something like you love it when you find something that's the answer that you already want to hear, right?
Mhm.
This is like the typical thing. I really had, especially doing like hundreds of urine drug screens a month. I've always kind of questioned the utility of the process, and also I've always wondered, like, first of all, it's a cost to the patients, a cost to our healthcare system, and then like, what do I actually do with this information, even an unexpected result? Um, so with that information, I no longer require UDSs at every visit for every patient. So I've kind of changed my practice over the past year. I pretty much routinely conduct UDS testing during the first 6 months of treatment in my office. But after that, I actually I use a random number generator to kind of select a subset of my patients at each clinic visit. That way, I'm not doing it on everyone. And actually, it's been one of the biggest. It really makes my patients feel like much more engaged. I feel like they are, like, when they go, "Oh, do you need a urine drug sample today?" I go, "No, not today." And you can tell there's like a little smile on their face, like they feel that I trust them, because I do. And I'll tell you, a big win with my staff. My staff, like, are just loving the fact that, like, we don't have cases of these. Like, we have far fewer UDS cups at the office. Still a lot, but I mean, compared to before, where I was going through cases of those a week.
Well, it's also, I really like that you did random because I do feel like there's a lot of bias in addiction medicine and doctors get sucked up in that too. And, we see this when we take new patients. If you're a quote unquote good patient and you're on the doctor's good side, then you get special favors, be it you don't have to do your own drug screen, you're allowed to violate clinic rules, whatever. And if you're a bad patient, then you get kind of the hammer comes down on you. And it's very easy to get, as a doctor, when you have these intense relationships with patients, to get sucked into like a bias situation. Because you do feel friendly with some people, you like them, you know them well, you want to do them favors. And so doing that random number generator, I feel like it's a great sort of solution that's not biased. So I'm glad you do that.
Yeah. Anyone that wants to get feedback on how they do it, or if they do it differently, or if they think that I'm totally off base here, I'd love to hear it.
Yeah, I think it's cool. I do at our clinic because I do a lot of video visits. So I try to get 2 urine drug screens a year. So anyone who hasn't had one in the last 6 months, I do. And then I'll do anyone who's unstable or I need some accountability for some reason, or, like newer patients. And then after that, I try to do like you, like 6 per session. So I see how many are left after that, and then I random number generate the remaining patients. So I've taken your lead on that one.
It was cool.
So if you like these 4, we're going to do 4 more cases in the next episode. So you can tune in again in 2 weeks to hear that. And until that time, thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. Tell us which of these 4 articles you like the best. Tell us if any of them changed your practice, and we would love to include your comments on a future episode. You can email us, you can contact us on social media, you can join our Facebook group, and we'll put the links in the show notes. Original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.